would like to invite Dr. Sonu Goel, sir, to give his talk on bringing back that smile, achieving the elusive 6-6 on day one in smile surgeries.
A very good morning, and thank you for making me a part of this course. And I think the talk from Rohit is very elusive. I think yes, we actually need to explore the machine, and there are certain areas where actually you can go and explore. So the topic given to me is bringing back that smile, achieving 6-6 on day one in smile surgeries. So I think the goal of all of us as refractive surgeons has been 2020 day one. So a quick look, thanks to Dr. Rupal Shah for sharing this journey. So the journey of Smile started in 2006, and it was when Secondo and Blum, commenced the first lenticule extraction. And the world never knew that this could be one of the laser platforms that would establish, and major lenticule extraction would, translate into one of the major kind of refractive surgery. So we all know that the key steps in smile surgery basically include the lenticule base, and this is the base which takes around 10 seconds, the side cut 2 seconds, the cap cut around 12 seconds, and the cap side cut around 2 to 3 seconds. So these are the four key steps when you're addressing a lenticule on this platform. A quick look on what happened initially. So when the trials started and the machine came up, it was the scan pattern A. So what I really mean with the scan pattern A is when you're cutting a lenticule, you're doing a spiral out. So what does this translate into? So when this was the lenticule cut and it started the spiral from the center, and as it was moving, these gas bubbles were causing disruption of the cap cut here. So what actually translated was this kind of dissection of the cap. Now this is what actually was inhibiting day 166 in the earlier platforms. And this was the transition when Dr. Rupal and her group gave to the world what is called the scan pattern B, and they started what is called as the spiral in, what we see now for the lenticule dissection, and the spiral out for the cap cut. And that is what actually transformed into 2020 day one. So this was a breakthrough in the lenticule dissection in on the Visumax platform. And we all know that achieving a good vision quality on day one is basically linked to a lot of qualities of the laser system that we use. So high pulse repetition rate. So initially on the Visumax 500 platform, we had it was a 500 hertz machine, but now with the 800, it is 2000 hertz. So high pulse repetition, reducing the time. It gives you you have to have a very low and a very stable laser energy so that the lenticule dissection is quick and easy, and the ultimately transforming to good quality vision on day one. And the laser has to be accurate in focusing, and there has to be a very small spot. So the spot sizing now translates from 4.5 for to almost 3, the spacing, and 1.5 for the side cuts, and that is what translates into a very smooth dissection, ultimately leading to what is 2020 day one. So this 800 is a 2000 hertz, which basically boils down to the total duration from 28 seconds to almost 10 seconds for the lenticule, and 5 seconds for the flap. So basically the shorter suction time increases the peace of mind both for the surgeon as well as the patients. And yes, a lot of research, which I'm sure Rohit will take forward into dry eye, and what is the effect of the suction duration reduction vis-a-vis induction of dryness post-operatively in these patients. So suction loss has been the biggest bug, and we all know through various multi-center studies that it is almost close to 1.34%, and 52% of the suction loss usually will occur during the first half. That means the 13 seconds of the surgery in this Visumax 500 platform. So boiling down to the duration, when the reduction of the whole treatment goes down to almost 8 seconds. So gone are those days when you actually found the suction loss. A very good paper in Cornea by Dr. Tatyal and his group came out that the learning curve of smile is basically the dissection, and it is the dissection and extraction which is the most challenging step for these smile surgeries. And you have when the spot spacing reducing from 4.5 to 3, and the side cut to almost 1.5. Gone are those days when actually you would find patients with stromal damage or anterior cap tears or side cut tears and retained lenticules. So the dissection becomes very smooth, and these complications, which we normally now find in literature and hardly we experience with the best of the hands, basically ultimately translate into the patients having 20/20 vision day one. One great feature with the 800 platform is the central line. We all know that if the decentration is more than zero point 0.3, there is induction of aberrations, specifically the coma and the spherical, and that is more translated when you have a high level of astigmatism, maybe more than 2.5. So the center line system, if you watch here, basically you need to align this visual axis onto the center of the circle, and this takes care of the angle kappa. Shortly we'll have the equipment talking on the forum where the atlas would be linked, and the XY on the atlas would directly be on the Visumax 800. So the alignment would exactly be what is required as per the topography picture on the Atlas equipment. So a quick look of what we do in our OR, and how does this equipment behave, and how do you translate good quality vision is a good clearing of the meibomian, drying, and this is how so there are two arms to the equipment, and this is the operating microscope. This would swirl, and then the laser microscope comes in, and this is the disposable suction device. So this is the joystick, and this is rotated, so the laser delivery system cone comes down, and this is the suction device which is hooked, and the other end onto this laser delivery and gets self illuminated. And then you have this graphic interface display where you are, and this is what the centration I'm talking about. So if you have you ask the patient to look in the light, the center, the circle is threaded, and just ensure that it remains within this. So the decentration would be less than zero point 0.2. So 80% once it is achieved docking, you apply suction, and this is what the spiral in, and this is the spiral out that I was talking, the side cut, and it is just 8 seconds that the whole procedure is completed. So actually this translates into almost no suction loss. So almost 400 eyes over a period of 5 months that we did, not even a single patient of suction loss. So this is, just watch the smoothness with which we are able to dissect. So I go down, I go under the cap, and this is very slowly, very gently, and without any effort, very smooth dissection under the cap. I go underneath the lenticule, I go left, leave a stump there, go slightly on the right side, dissect it 360, and then release the stump that I've created. And Gaurav has taught us this wonderful hydro expression of the lenticule, and this is what actually translates day one. This is the slit lamp picture. You hardly can make out any sign of surgical trauma, and basically translating to a good quality vision day one. Another very important feature with this equipment is the oculine system for the cyclotorsion alignment. And on the fly, this machine can be hooked to the ILMaster 700, where the pattern of the vessels can be recognized, and the astigmatism can be actually be controlled. But since this is yet to be released, so initially what we do is we mark alignments here, and the moment we take the patient on the fly, you can actually, after applying the suction, you just see, watch, you can rotate and you can align the pattern according to the desired axis. So the treatment is bang on target, and whatever in the literature talks of the cyclotorsion close to 3.3 or 4 degrees, I think this can be taken care, and specifically in patients with high astigmatism. So all of this ultimately boiled down to our initial results, where the spherical and the cylindrical equivalents have been almost close to zero. And one very interesting study that we observed, is the reduction in the mean HOA. So there was a significant reduction in the post-operative HOA in our initial cases, series of cases that we saw. And this all boils down to a better refractive outcome under this platform. Predictable, it's quite safe, patient is very comfortable day one, and the ease of workflow is amazing, and basically boiling down to less surgical and OPD man hours and peaceful nights, and ultimately patient achieving a good 2020 day one. Thank you once again.
Thank you, sir. While Dr. Saurabh sir is setting his presentation up, I would have two questions. So there are a lot of times that we come across dense OBL after the laser has fired, and when we try to dissect, patients are extremely not cooperative because they can't see the white light to concentrate on. What would you do in those situations?
So it's quite tricky what you're talking. So it actually depends upon your own personal experience, and you really need to take the patient into confidence, and you really have to be very, very careful that you don't accidentally cause those cap tears in those circumstances. So I think patience is the first thing that I would, like to add to this. The second would be the right instrument, because using anything sharp would, actually cause chances. Biggest pearl that I feel is the best for these conditions.
Thank you, sir. And you remove the lenticle while doing the like you dissect it and then you hydro explant the lenticle. Do you think using hydration in the interface would lead to?
Yeah, so that's a very nice question, and there has been quite a debate on this now. So the dissection is so smooth that now actually you don't need to, even hydro express it. You can just hold it and just pull it out. So I think yes, that could be one thing that now we are slowly, from hydro to just simply pulling it off.
Thank you.